Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Tina Lockwood from the University of Washington School of Medicine and Dr. Stacy Gray from City of Hope, co-chairs on Circulating Tumor DNA Testing in Solid Tumors and Lymphoma, ASCO Guideline. Thank you for being here today, Dr. Lockwood and Dr. Gray.
Thanks very much for having us.
Excited to be here.
And then just before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Lockwood and Dr. Gray, who have joined me here today, are available online with the publication of the guideline in the JCO Oncology Practice, which is linked in the show notes. So then to dive into the content of the guideline that we're here today to talk about, Dr. Lockwood, could you provide a general overview of both the scope and purpose of this guideline on ctDNA testing?
So this ASCO guideline provides evidence-based recommendations on how circulating tumor DNA, or we'll call it ctDNA throughout the podcast, should be used in patients with solid tumors or lymphoma. It's really important to note that this guideline builds on an earlier 2018 ASCO CAP systematic review of ctDNA, and that evaluated the analytical validity and early clinical applications of ctDNA. It's been a number of years, and now we're progressing to this guideline. So it was developed through a systematic review of studies that were published from 2017 through 2025, and we included a multidisciplinary expert panel. The goal really is to develop this guideline to help clinicians understand where ctDNA testing has clear clinical value and where the evidence is still emerging. The guideline evaluates several potential uses, including treatment selection, molecular residual disease, or MRD, response monitoring, recurrence surveillance, and prognosis. So really, we tried to look at this comprehensively as far as how you could use ctDNA testing for patients. Dr. Gray, is there anything else that you wanted to add?
One thing I wanted to add is that our guideline is intended to bring structure and consistency to a really rapidly evolving field where use of ctDNA is really outpacing clear evidence. And so we wanted to deeply dive into the evidence to try to help say where we have clear clinical utility and where we might need to do more research.
Understood. I really appreciate that context and background from you both to set the stage for this guideline. So then next, Dr. Gray, I'd like to review the key recommendations of this guideline. So starting with, when should ctDNA testing be offered to patients?
In reviewing the literature, we found some key places where ctDNA should be used. First, when we think about treatment selection, when we're trying to identify the specific molecular alterations within a tumor. So if tissue testing, which is the preferred method of testing for molecular findings, when tissue testing is either difficult, it's unsafe, or it's infeasible, then we clearly think that ctDNA should be offered. The second area is when tissue results are not available in time to guide management. So sometimes our patients are very, very sick and we need to start treatment very quickly. And so oftentimes we can get the results of ctDNA testing more quickly than we can get the results of a diagnostic tissue biopsy and molecular analysis on that. So if time is of the essence, then it's a very helpful modality. We also know that there are times when the drug's regulatory approval either allows or requires ctDNA testing to select a specific therapy. That's another really good time to use ctDNA. But we want to make sure that we're really only offering ctDNA testing when the results are affecting clinical decision-making. And sometimes if tissue testing is negative or inconclusive, we can use ctDNA testing to kind of help to understand further or to add clarification to the molecular testing. So those are the big areas when we would want to think about using ctDNA testing. Dr. Lockwood, any other comments about that?
No, thanks so much, Dr. Gray. I'm going to repeat something that you said, and you said it early, but as someone who's in the pathology and lab medicine side of things, it bears repeating the fact that if we have circulating tumor DNA results that are negative or inconclusive, tissue-based testing should be pursued whenever it's possible and feasible. And of course, everything that we want to be doing is to inform clinical decision-making. That's really the goal for this guideline and for all other guidelines.
Absolutely. I think you both raised some very key points there on where ctDNA testing should be offered. So then the panel was also explicit about where ctDNA testing should not be offered. So to provide some further clarity to our listeners, Dr. Lockwood, in which situation should ctDNA testing not be offered?
Yeah, that's a great point, Brittany. Because we are moving so quickly in this field and really in all of clinical oncology, we do want to think about where there's evidence and where there isn't evidence. So because we're talking about all solid tumors and lymphoma, it's a pretty broad statement that we're going to make. And what we came up to with the expert review was if the results would not change clinical management, ctDNA-based testing should not be used. It also should not replace standard of care testing. That includes imaging. It certainly also includes tissue biopsy, and we want those standard of care applications to be continuing. There's also no evidence currently that ctDNA testing can fully replace what our current standard diagnostic and monitoring strategies are within clinical oncology. And of course, it should not also be used solely for prognostic information without an actionable intervention. So we really want to think about that informing decision-making.
Great. I appreciate that context around where ctDNA testing should not be offered. And it seems like it's just really important when it informs clinical decision-making. So then the last recommendation that the panel put out, Dr. Gray, what does the expert panel state regarding fractional, percentage, or concentration-based measures of ctDNA or total cfDNA concentration for clinical decision-making?
Brittany, that's a great question. And I think an area of very, very active investigation right now. We, as a guideline committee, do not recommend using fractional, percentage, or concentration-based measures of ctDNA or cfDNA as surrogate markers of disease burden for clinical decision-making. We really do not think that in a regular practice that these types of tests should be used to guide treatment decisions. And really, we want to gather more evidence in this area through clinical trials and other research studies so that we can better understand what these types of findings mean and how to best apply them to clinical care.
Definitely. And we'll look forward to seeing how the research expands in this space and how the recommendations may change in the future as well. So then, as you mentioned earlier, this guideline addresses all solid tumors and lymphoma, so it affects a wide variety of clinicians. So Dr. Lockwood, in your view, what is the importance of this guideline and what should clinicians know as they implement these recommendations?
Some of the key takeaways that the expert panel came up with in this space is that circulating tumor DNA has very strong clinical validity, but limited clinical utility in many settings. So really the evidence base is still coming to fruition. Many studies show that we have the correlation between ctDNA with prognosis, but fewer that are demonstrating that acting on those results actually affects our clinical outcomes in improving, therefore patient care. So the guideline helps clinicians distinguish between the validated uses and what we consider still to be investigational applications, where we're very excited to see more clinical trials happening and excited to see what those findings are once they're published. And also I'll point out that clinicians should remember that ctDNA tests have high specificity. So we really are anchoring on not having false positives, but we want to make sure that the sensitivity is understood as well. It's really a moderate degree of sensitivity. Wide variability there, but we don't think that the sensitivity is as high as the specificity. So the negative results really may still require tissue confirmation.
Excellent. Well, thank you both for reviewing the recommendations and what clinicians should know. Expanding on that a little bit, Dr. Gray, how will these guideline recommendations affect patients with solid tumors or lymphoma?
I think that these recommendations are very helpful in terms of both providing clinicians with much more clear guidance on when to use testing and when to not use testing, which then also I think they can be confident when they're talking to their patients about where we have evidence that this improves clinical outcomes and where it doesn't. For patients, kind of what we were talking about at the top of the podcast, right? If patients are really sick and they need treatment quickly, ctDNA testing can provide very fast access to genomic information that can make a huge difference in terms of starting therapy quickly. I think that for some patients, for example, who have maybe metastatic disease to the bone, that would be traditionally hard to do tissue biopsies to get molecular information, that this provides a really nice alternative to that. It can also be less invasive for some people. There are some people who have tumors in places that are very difficult to biopsy. And so this provides a really nice and safe option for patients. As we said earlier in the podcast, it's really important to know that if you get a negative test or if you get a test that's inconclusive, that pursuing a tissue biopsy and really talking to your provider about the importance of getting a tissue biopsy to make sure that patients don't have targetable molecular alterations is essential. The less invasive nature, fast access to genomic information is really, really important. But we want patients to know that doing tissue biopsies still really plays a big role in oncology.
Yes, this guideline really helps to outline where there is and where there isn't evidence. And so, as you've both mentioned throughout this podcast episode, the evidence base here is limited in some ways, and there's a lot of clinical trials in progress as well. So, Dr. Lockwood, what are the outstanding questions regarding ctDNA testing?
There are so many outstanding questions regarding ctDNA testing. And I think that's exciting because I think that means there is a lot that's still to be learned and new ways that we can open this area of testing, going back to what Dr. Gray mentioned with respect to this potentially being less invasive and more rapid for patients. There's a lot of enthusiasm about molecular residual disease, or MRD, and I think that that's an incredibly exciting area for us to be exploring as a field, to be using clinical trials to establish a very strong evidence base. And that's an area that we do have some recommendations, but we think that a lot more evidence is going to be coming to the literature soon. We know that the trials are underway. So when you think about ctDNA positivity after surgery, strongly predicting recurrence across many cancers, I think that that is an evidence base that we will see more developed in the literature with additional clinical trials. As a laboratorian, a piece that is important to me is standardization issues. So when we think about does one result transfer to another result, there's no universal definition of what MRD is. You've heard me say molecular residual disease because that's what we've said in this field, but we call it a different thing in other fields, right? We call minimal residual disease or measurable residual disease. So that's just in what the language is. And there are some guidances around that. And certainly the different types of assays and technologies that are used, what frequency you would perform testing, those are all areas that really need to be developed. I'd say one other broad category that is not addressed in this guideline is the issue of when we think about screening asymptomatic patients in a general population setting. So sometimes this is called multi-cancer early detection, or MCED, and that was outside of scope. The expert panel really quickly came to that position when we looked at the evidence base. So we don't see that there's at this point evidence that MCED screening improves cancer outcomes. We know that clinical trials are underway. There have been some recent ASCO policies and positions that have been put out in this space. And I think that large population studies will need to continue coming out for us to have a strong evidence base. Dr. Gray, other outstanding questions that you think that would be helpful for us to highlight?
Yeah, I wanted to just add 2 points. I think, Dr. Lockwood, you said something that's really important, which is that in the MRD, or molecular residual disease space, we have some really, really nice trials that have come out that are outlined in the guidelines that show when MRD is helpful and when it should be used. And that brings me to my second point, which is that one of the areas that really also very exciting going forward is thinking about if and how ctDNA might be used differently in different contexts. So one of the things we need to fully figure out is, does the use of ctDNA, whether it's MRD or for monitoring, whether that looks different in the context of breast cancer versus colorectal cancer versus bladder cancer versus prostate cancer, right? And so one of the things that we came to a consensus about as part of our guideline development is that a lot of these issues will probably best be addressed in the disease-based guidelines going forward, because there is so much specificity in terms of each of the particular clinical contexts. So that outstanding question is, does this look the same across diseases, or does it look different across diseases? And I think that that will be really interesting to learn about as we go forward. We know in general that molecular findings and genomic alterations don't always behave the same way in different tumor types based on tissue testing or based on ctDNA testing. So how this information helps us shape care might look different too. So I think that's another really exciting and unexplored area.
It certainly is an exciting time for research into ctDNA testing, and we'll look forward to the ongoing trials in this field to impact future guidelines. And as you said, Dr. Gray, particularly in specific disease site areas, this guideline really lays a foundation for the guidelines to be developed and have nuance for how it may impact colorectal cancer different than breast cancer and all the different disease site areas. So I want to thank you both so much for your work to develop this important guideline that is widely applicable across oncology. And thank you so much for your time today, Dr. Lockwood and Dr. Gray.
Thank you so much for having us.
Thank you so much, Brittany. It's wonderful to be here.
And finally, thank you to our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/molecular-testing -and-biomarkers-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.